Good morning, my name is Sonia Tello. I am an industrial engineer and ergonomist. I work as an ergonomics consultant at the CENEA Applied Ergonomics Center, located in Barcelona, Spain. I have the honor of being part of the largest international school of ergonomics in the world, which is the International Ergonomics School. Within this workshop I want to share my experience on how risk is managed by the manual mobilization of patients or people in Spain in the healthcare and social healthcare sector. In Spain we have a high percentage and a high rate of health problems in workers who take care of our health. Mainly these problems are musculoskeletal and are located in the lower back. If we look at Europe, we can see some statistical data where the prevalence rate of musculoskeletal disorders in workers in the health and social health sector is much higher than the data we may have in other sectors of activity, such as agriculture, industry or even construction. Also, another interesting fact that is not very different in Spain is the fact that workers in the health sector or in the health sector indicate that their problems or are affected are mainly exposed to back problems. Back pain. We see in this graph how 27% of women in the health sector say they have back problems. 24% of women in the health sector say they have problems, muscle pain, and 46% indicate that they must mobilize people or patients for at least 1/4 of their working day. In Spain, if we look at some data collected about 10 years ago, we have that occupational diseases, according to the classification of occupational diseases, shows us that 83% of occupational diseases are caused by physical agents. If we are to identify which physical agent this 83% corresponds to, it can be seen that 84% of that 83% correspond to musculoskeletal disorders. If we see, for example, in the health and social health sector this percentage already increases from 84% to 94% of cases derived from musculoskeletal disorders. And well, the question is, what is being done in Spain to reduce this high percentage of problems, diseases and musculoskeletal disorders in the health and social health sector? Well then, what has mainly been done, since the year more or less 90 and the year 2000, is to begin to show this problem. Workers in the health sector, nursing staff, nurses, begin to suffer from these pains in the lower back. In this context, work began on what is called occupational risk prevention. In Spain, in the 1990s, the occupational risk prevention law was established, and from there work began on what can be done to reduce the health problems of our workers. And it is at this time when the gaze begins to focus on the socio-sanitary health sector and some methods or some ways of being able to assess what these ergonomic risks are in the personnel that mobilizes people and patients. And what solutions are proposed? At first they proposed what is commonly called the back school. The back schools promoted a lot of training, including therapeutic type, where our workers from the health and social health sector attended these back schools to learn how to take care of their backs. This was also accompanied by some techniques defined in the DOT method on how to carry out the mobilization of a patient with the best possible posture, with an adequate postural technique, with adequate knee flexion, etc. But within all this framework of mobilization techniques, work was always carried out manually. The concept to take care of that back is to perform the best possible technique, but always mobilizing and lifting these patients manually. At the methodology level, for the proper assessment of ergonomic risks, well, at that time, only the REBA method and, in some cases, the RULA method were used to try to identify what the problems were. The issue is that after many years working, let's say with these ways of trying to improve the health problems of our workers, incidents continued, problems continued to exist. As I have just shown you, in 2010 we have a high percentage of musculoskeletal disorder problems in the health sector. Does it mean that what we have done before has not been efficient? It means that the back school is just an aid. The adoption of DOT method techniques obviously contributes. Trying to do ergonomic risk assessments helps, but has not been effective. These strategies have not really contributed to a reduction in the number of casualties, in the number of occupational diseases due to musculoskeletal disorders in the health and social health sector. In 2009, well, some interested in being able to improve these conditions in Spain. What we did from CNEA was go looking for the best. And we found that, within the International Ergonomics School, a specific methodology had been developed to be able to manage the risk due to the manual mobilization of patients or people. We ask for the support and collaboration of Olga Menoni and Natalie Butteville, the creators of this methodology, and we began to work with them to be able to bring and adapt the methodology to Spain. We do a lot of separate work, as my colleague Diana already explained, translating, adjusting everything, the tools and the material, to be able to apply it in Spain. In addition, working in collaboration with the authors of the method, taking advantage of their vast experience, we also began working with them to train occupational risk prevention professionals in Spain, so that they could apply the methodology in their centers, hospitals, and nursing homes. Likewise, being able to know what the best mobilization techniques were, always using the aid teams. It is thanks to this experience with the authors of the MAPO method, to the work carried out over many years and with the reinforcement of the arrival of the ISO TR 12295 standard, that in Spain, it was possible to introduce in a more solid way the need to apply a specific methodology for the evaluation of risks due to the manual mobilization of patients that would give us relevant and adequate information to be able to begin to manage and reduce this risk. And we obtain that, through the arrival of this norm. This normative document ISO TR 12295, we were focusing on the problem and we could obtain, by evaluating the organization of work in hospitals and geriatric residences, verifying what type of patient is that has to be mobilized. What are the aid teams that we have at our disposal? Where are these patients mobilized? What are these spaces like? Whether they are adequate or not. And a determining factor is the training of our workers to carry out these formations, those adequate mobilizations. Well, we saw that everything that this technical document told us was collected in a very appropriate way. The MAPO methodology. The MAPO methodology provides us with internal validation. It gives us the power to obtain a risk index that has an association with the probability of appearance of the musculoskeletal pathology. This richness is only provided by the MAPO method within the methods proposed in ISO Trail. And, therefore, in Spain, we adopt the application of the MAPO methodology for health centers and residential centers. In Spain it has been applied throughout the Spanish geography because many prevention technicians have been trained. Who is the figure in Spain that carries out this specific risk assessment in the health and social health sector? However, here I wanted to capture graphically. At CENEA, we have worked on the evaluation, assessment and management of some large hospital centers and some geriatric residences. We have mainly worked with residences that belong to different regional governments, the government, for example, of the Basque Country, where we have carried out joint work to train the technicians, verify the conditions of these geriatric residences with this MAPO methodology and see how we can make continuous improvements to reduce the risks of caregivers and gericulture workers of the elderly. We also work with the government of Catalonia, in all geriatric residences managed by the Catalan government, to assess their risks. The risk of geriatric workers in these residences and work on improvements and risk reduction. As for hospitals, we currently work with large hospitals. In the region of Galicia, work is obviously done in hospitals, also in Catalonia, due to its proximity, and in Valencia. Well then, in the application of all the adaptations of the methodology to each one of these hospital centers and these residences, we have obtained some results. And these results in general, tell us that in nursing homes in Spain we have a high level of risk. %40 of these residences and the units analyzed in each of these residences have a high risk level. What does it mean? That it is important to manage and propose intervention measures to reduce the percentage of workers who are exposed to this high level of risk. But it is that, in addition, we have a high percentage of medium risk level, and a half means there is risk. And only 11% of the nursing homes in Spain that we have analyzed have an acceptable level of risk. If we go to the results of the hospitals, we have slightly worse results. Almost 70% of the units analyzed in hospitals in Spain have a high-risk index due to manual mobilization of people or patients, and only 11% have an acceptable risk level. Therefore, it is necessary to act. It is necessary to start intervening and evaluating, to have an indicator, a quantitative value, that we can compare once risk reduction management begins. And, mainly, what are the determining factors of these risks? Well, in residences, 55% is due to the fact that workers, geroculturists, geriatric assistants do not have adequate training in the mobilization of people or patients. We have an inadequacy or absence of aid equipment for the mobilization of people or patients, such as cranes, such as sliding sheets. And this corresponds to 63% of the total factors that are present and determine these risks. And on the other hand, we have that 72% corresponds to an inadequacy or non-existence of minor aids, such as sliding tables, sliding sheets, ergonomic belts, or even the standing crane. In hospitals, this percentage is higher. Generally, in geriatric residences in Spain we find a greater presence of support teams. We find that today the use of cranes is quite high. Residences do not conceive of having non-cooperative patients or very dependent patients without having some important support team within their units. However, in hospitals this is not the case. In hospitals we have very few aid teams. The use of cranes is not so high, mainly because the spaces in hospitals are not wide and we have problems mainly in rooms where there are 2 patients. Therefore, if there is a lift in a unit within a hospital, if we have a double room or with 2 patients, the use of the lift is not possible. That is why there is an inadequate support team. About 75% of hospitals in Spain. We need to improve the use of these aid kits or improve the spaces so that the aid kits can be used. The lack of training in our nursing staff is very high. We find cases in which the training received by the nursing staff on manual mobilization of patients or people has been given when they have completed the training to be nursing assistants or nurses, but not within the hospital. We are now suffering from the post-pandemic effects of COVID, where, in addition, during these years, it has not been possible to carry out specific training on the manual mobilization of patients or people. Good. All this to understand that in Spain we have high percentages of problems regarding high risks in nursing homes and in hospitals with risks above 5, high, and with medium risk, where we must begin to think about carrying out actions and adopting measures. Preventive measures to reduce those levels of risk. The percentage that the results have produced is that 11% of residences or hospitals analyzed, since they have an acceptable or absent risk. And here what we must do is continue to carry out control, monitoring to prevent these units from ever having an upturn in non-dependent or dependent patients or an upturn in a problem that generates an increase in risk. And then, through this panorama, how do we give effective solutions? How can we improve these risk levels? Well, thanks to the preventive strategy of the MAPO methodology, we can, based on these results of these risk assessments, work the management circle through continuous improvement, where in the short term we can propose that they be selected, implemented and start to be implemented. Use some assistive equipment. Minor aids are needed in units. Provide and carry out specific training for the use of this equipment that is necessary in these units. And think, in the long term, of some structural interventions, those spaces necessary for the mobilization of patients or people, and verify over time that these interventions have been effective. Well, I want to show how in Spain we are trying to address this problem in some residential units and how we can gradually reduce and quantify, through reverse engineering, what these determinants of risk are. What are these risk levels due to and how can we work on each of these factors? Proposing measures and simulating the impact of ergonomic intervention to reduce these risks. In this example, we have a residence where the risk assessment is carried out in a plant. On that floor we have 70 residents, 70 people, older adults who sleep in this residence, and we have a high-risk index result, with a value of 6. And this would be the composition of the MAPO equation, the MAPO index that yields this result. Well, as we can see, we have some factors that are intervening in this result. One of the first quantitative values that we have is that the number of operator workers present in the 24 hours in this plant is 22 to mobilize the type of patients or residents that we have in this unit as 46 dependent patients. This index is very high. Therefore there is a lack of personnel to be able to carry out adequate mobilizations and have less load or less frequency of mobilizations. Another factor that we identified is that of minor aid. The factor of minor aids is related to not only the presence of minor aids in this unit, but also their use and whether their use is appropriate or not. And we have that, in this residence, on this floor, only 6% of the partial lifts are carried out with some kind of help. So here we have another determinant of this level of risk. And another identification of the determining factor, the multiplying factor to the surrounding environment. Due to the fact that the bathrooms where hygiene is carried out, where patients are carried out or taken to the bathroom or toilet, do not meet the adequate space requirements to be able to access with a wheelchair or to be able to access with a crane. Well, given this panorama, we clearly identify the points where we must act and where we must propose improvements. If other different improvements are proposed, attacking other different aspects, surely there could be some kind of improvement or reduction in the index, surely, but that is how we are going to obtain the most effective interventions. Let's see, for example, if we went from 22 auxiliary geriatric cultivators in this plant and increased the number of geriatric cultivators available in 24 hours to 30. Well then, we would reduce the risk level by 25%, going from a high risk level to a medium risk level, although we still have risk. Therefore, the only solution is not to increase the staff or not to place more staff. Well, let's see what might happen if we improve the use of aids for partial lifts or for lifting or mobilizing partially cooperative patients. Well, only if we carry out an adequate procedure for the use of the standing lift and specific training is carried out for geriatric workers and nursing assistants so that the lift can be used with partially collaborating patients to transfer them, for example, from the bed to standing or from the bed to the wheelchair or from the wheelchair to the toilet, then we would get to obtain a risk reduction only applying this measure of 79%. We can see how we would reach an acceptable risk level just by implementing this measure. If we then worked with the risk factor corresponding to spaces and accessibility, for example, in the bathrooms, in those bathrooms that were with reduced spaces. Well, by improving those bathrooms, installing, reforming and making them more accessible, we would reduce the level of risk by 40%. Therefore, from this slide and from this scenario we can conclude that only by carrying out adequate training in this case and in this residence for our nursing assistants to use the standing lift with partially collaborating patients, we would already have a very significant risk reduction. Significant. And, therefore, it would not be necessary to increase the staff or carry out the reform in the bathrooms. This is the richness and the greatness of being able to get a risk assessment in such an exact way, where we can then go back, through this reverse engineering, to read what the problem is, where is that focus of attention and how can we reduce this risk. Let's see another example, also in a residence where 4 floors or 4 units are analyzed and the results of these 4 units give us medium risk levels. When we talk about the medium level of risk, we are talking about the level of risk, that is, we are in the presence of risk. In this residence we have 2 determining risk factors. One of them is that only 30% of partial lifts are done with help. And the other factor corresponds to the training of the nursing staff trained in this residence. It corresponds to less than 75%, and, therefore, we must act on these two sources in order to improve these levels of risk, which, although they are not red, are not as high, but they are still risk. Well then, it is proposed to provide sliding sheets and, at the same time, train at least 75% of the nursing staff of this residence for the proper use of these sliding sheets. Mainly, the objective is to train these workers in moving towards the head of the bed, with the sliding sheet for all non-cooperative and partially cooperative patients. At the same time, that all postural changes from supine to lateral decubitus are performed with the sliding sheet in all non-cooperative and partially cooperative patients. Also, repositioning in the wheelchair when our patients slide in the wheelchair. We are looking for this relocation to be done with the sliding sheet. Well, with this endowment and accompanied training for the use of these sliding sheets, we have a reduction between 60% and 80% of the risk levels, having a very high intervention effectiveness, achieving that our nursing workers of this residence are affected by the probability of the appearance of damage in the lower back. Area, the same as that of a worker or a person who does not mobilize patients or people. From the results we have in a hospital that we have worked with, the initial risk map in this hospital is like the one we see on the screen. We have 15 units with risk, yellow risks, red risks and only 3 units with acceptable risk. Work begins on this entire management system, proposing specific intervention measures for each unit, depending on its determining risk factor. If the determining risk factor is the aid teams, if it is the minor aid, if it is the training and ultimately the proposals have been of a structural nature, if they have to carry out some type of reform in the unit. What are the results we have today? Well, we have a hospital where 10 risk units still prevail. But as you can see, compared to the previous slide, we no longer have any units with high risk. We have managed to reduce the units with high risk to medium risk and many units that had medium risk, yellow, to acceptable risk. Management is effective. The hospital's investment has mainly been in training its workers, in carrying out adequate specific training for the mobilization of patients or people. And, as a result, gradually introducing minor aid in some units, mainly, which was what did not exist in this hospital. Slider sheets mainly. Well, as a strategy to reduce and manage risk in hospitals and nursing homes, I want to introduce you to the Ergo Ladiers program. The Ergo Ladiers program. Developed by the authors of the MAPO methodology, by Olga Menoni, Natalie Batvey and their team. And this program, Ergo Leaders, also in line with the technical document ISO TR 12296, What it seeks is, mainly, to reduce these musculoskeletal disorders of the nursing staff, improve the quality of care, but that the center itself or the hospital itself manage your own risk and your own training. This program is carried out in a hospital in Catalonia and arises as a need to offer training to the workers who carry out the mobilization of patients, but that can be carried out by the hospital itself, which manages it, so that they do not depend on an external entity that comes and do the training and leave, but rather that they themselves be the ones who can carry out training and recycling their own nursing staff. The objective was that in 2 years it would be possible to have 75% of the staff adequately trained and obviously reduce the incidence of accidents and musculoskeletal problems. Well, this program also responds, as I was telling you, to the experience of several countries at the European level and outside of Europe that have used a figure similar to the ergo leader, such as ergo leader. It is called peer leader. In Italy, in the United States, workover in Australia, etc. Well, the idea is to form work groups that are trained, that have a much higher training in ergonomics than their colleagues, and that these groups work towards the prevention of musculoskeletal disorders within each one of the units of a hospital or a residence, and that they are multi-professional groups that are made up of nurses, physiotherapists, gerocultors, nursing assistants. And this allows the different disciplines to make the effectiveness of this project successful. Who is an ergo leader? Or what does this ergo leader do? Well, this ergo leader is a hospital or nursing home worker who mobilizes patients or people, be it a nurse or a gerocultor or a nursing assistant. He is the one who will be in charge, being ergo leader, of training his own colleagues on the specific use of the aid teams or aids. The ergo leader will be in charge of ensuring that everything that has been taught in training is applied, day by day, in each of the units in which the ergo leader works. In addition, this ergo leader will have the knowledge and power to identify possible improvements that can be introduced in the unit, where he works or in other units. And, ideally, it is that our ergo leader or our group of ergo leaders contribute to verifying that the training that has been done is effective, that they have really been taught to move to the head of the bed with the sliding sheet, day by day. That the group of nurses or the group of nursing assistants carry out this mobilization with the sliding sheet, and that it really becomes something common, not extraordinary, to carry it out with help teams. Well, the program that was developed in this hospital of Catalonia corresponded to 100 hours of training, where it was developed practically in 4 phases and it took more or less 24 weeks. The first phase was to start this project, in which all the nursing assistants designated for this project participated. Also physiotherapists from the hospital itself, trainers and most importantly, the Human Resources Department and the Risk Prevention Department. Here in total, in the Ergo Leaders program, 20 people were worked on and trained. The first phase was carried out in the classroom and corresponded to training work. How to identify the units in which each nurse or nursing assistant works. What are the activities that require mobilization? And if this mobilization is carried out in a manually or with help. And it was collected using a tool developed by the authors of the MAPO method, the activity diary. Once our workers, today ergo leaders of this hospital, learned to use this tool, went to their units and applied the activity diary, to later share it. In the next phase, we worked on mainly what support teams. What support teams does the hospital have? What support equipment could the hospital count on? And we worked on that selection of teams in practices on mobilizations with 100% aid teams to know and be able to use these teams in the most effective way, and also to test different teams so that the workers themselves could say which team is the best for them. Accommodates their situation, their reality, and being able to ask the hospital to buy them and provide them with the equipment that they already know, have worked with and want to be used. In Phase 3, our ergo leaders are asked to develop a series of procedures themselves so that, with their own jargon, they can say step by step. How a mobilization should be carried out. For example, from a non-cooperative patient from the bed to the wheelchair with a passive lift. And they themselves worked on these documents with our help. We helped them to mainly correct some aspects. But these procedures are their own procedures. The objective is that once they leave this program, they are put into operation, shared with the rest of the hospital, and they are procedures like those that can be used, for example, in the industry. In addition, ergo leaders have to train their peers. They prepare their formation. How are they going to teach their own colleagues to carry out the mobilizations in the most appropriate way? And we supervise all this training. Once these trainings are completed, our ergo leaders finally have their certification, their diploma. And, at the end of this project, around 150 workers have been trained in 1 year. Good. What are the expected results of a program like this? Well, in the short term, more or less between 6 months and a year. The objective is that of all nursing workers who are exposed to moving patients or people, 75% of them already have adequate training in manual patient handling. This means that the formation factor in the MAPO index will go from a very high value to a positive value, and we will significantly reduce the level of risk. And, in the long term, it is expected that between 1 and 4 years the incidence rates of absenteeism and occupational diseases due to overexertion accidents will be reduced, and that the mobilization of patients will be integrated in a specific way in the risk prevention strategy. That the focus of risk prevention is not only on biological problems, but also on ergonomic problems. That we can control that everything we are doing is being effective, and if not, make the necessary corrections. And above all, the most enriching thing for a hospital or a nursing home is that they are autonomous. They can carry out self-management to identify and assess risks, and, above all, they can carry out improvements without the need for an external company to do it for them. Otherwise, the center itself carries out its own self-management and continuous improvement. Well, this is the experience that I wanted to tell you about and that I wanted to share. I hope it has been interesting for all the countries where this type of program or methodology could be applied. And, well, nothing else. Thank you very much from Barcelona, Spain. And I hope that the Congress is being a success. A hug.